Yes, ready. Okay. So it's alcohol withdrawal syndrome. Okay. In alcohol withdrawal syndrome, if we go through the box first, in mild withdrawal, the symptoms are anxiety, insomnia, tremor, diaphoresis, palpitation, GI upset, and intake orientation. Onset since last drink 6 to 12, 24 hours. Seizure, single or multiple generalized tonic-clonic seizure, 12 to 48 hours. Alcoholic hallucinations, visual, auditory, tactile, intake orientation, stable vital signs, 12 to 48 hours. And delirium tremens, confusion, agitation, fever, tachycardia, hypertension, diaphoresis, hallucination, 48 to 96 hours. These patients delayed onset more than 48 hours. This patient delayed onset more than 48 hours following hospital admission of delirium, elevated vital signs, hyperthermia, hypertension, tachycardia, and diaphoresis in the setting of known polysubstance use. In the setting of known polysubstance use is consistent with diagnosis of delirium tremens. Delirium tremens is a late complication of the alcohol withdrawal that may affect up to 5% of the patient who experience an initial mild withdrawal syndrome. Delirium tremens does not present before 48 hours after the last drink, and symptoms may take as long as 96 hours to be seen. After onset, symptoms may persist for up to 5 days and are associated with a mortality rate up to 5%. Treatment of delirium tremens is similar to that the milder forms of alcohol withdrawal. Benzodiazepine, lorazepam, diazepam are the pharmacological treatment of choice. However, delirium tremens is the most severe form of alcohol withdrawal. Most severe form of alcohol withdrawal and usually requires management in an ICU. Do you want? Okay. Option A. Option A. Patients have psychotic episodes, may experience bizarre delusion, hallucination, but fever, tachycardia, hypertension, diaphoresis suggest delirium tremens rather than psychiatric disorder. Yes. Antidepressant discontinuation syndrome. Antidepressant discontinuation syndrome can occur when antidepressants are stopped abruptly or tapered too quickly. Symptoms are present with mild and include nausea, fatigue, headache, dizziness, agitation, and diaphoresis are possible, but fever and abnormal vital signs would not be expected. Malignant hyperthermia is characterized by muscle rigidity, rhabdomyolysis, hyperthermia, tachycardia immediately following administration of a volatile inhaled anesthetic, halothane, sevoflurane, in genetically susceptible individuals. Opioid withdrawal may present with agitation, diaphoresis, hypertension, and tachycardia. However, gastrointestinal upset, cramping, and diarrhea, flu-like symptom, pyeloerection, rhinorrhea, myalgia, and yawning are also typically present. Not be delirium and fever would not be expected. And the last option, post-operative encephalopathy, is most commonly associated with cardiac surgery. Post-operative encephalopathy is most commonly associated with cardiac surgery and presents with delirium or seizure in the immediate post-operative period. The delayed onset of these patient symptoms or her history of polysubstance use and the presence of abnormal vital signs making delirium tremens most likely. Okay. Is it ADHD? Okay. Okay. So this patient's symptoms, insomnia, impaired concentration, developing within 3 months of an identifiable stressor. 3 months of an identifiable stressor, job loss, moving back in with his parents are consistent with adjustment disorder. Patients with adjustment disorder experience an excessive response to a stressful life event that impairs daily functioning. Short-term psychotherapy is the primary form of treatment and focus on stress reduction, cognitive reframing, definition of realistic goals, and coping skill enhancement. In general, pharmacotherapy is used as an adjunct to psychotherapy when more rapid symptom relief is desired. Inpatient, inpatient short-term or as needed treatment with zolpidem can be used as an adjunct to sleep hygiene and psychotherapy to help obtain the restorative need to function. Zolpidem is a non-benzodiazepine receptor agonist, and has demonstrated efficacy in the treatment of uh, sleep onset and sleep maintenance insomnia. Okay, it's not methylphenidate. Is a stimulant used to treat ADHD, which is characterized by childhood onset and chronic impairment in attention and concentration. These patients' recent onset of distractibility and inability to maintain focus following stressful life event is more consistent with adjustment disorder. Got it? Okay. Although this patient desired to reduce alcohol intake, he is unable to control his strong cravings and is drinking increasing amounts. Pharmacotherapy should be considered. Pharmacotherapy should be considered in patients with moderate to severe alcohol disorder. Medication that target the reinforcing effects of alcohol by modulating opioid and glutamate function are effective. First-line treatment options include naltrexone, a mu opioid receptor antagonist, and acamprosate, a glutamate modulator. Naltrexone has been seen to decrease alcohol craving and reduce heavy drinking days, defined as more than 5 drinks for men and more than 4 drinks for women, and increases days of abstinence. It can be initiated while the patient is still drinking. It is contraindicated in patients taking opioid as it can precipitate withdrawal, and in those with acute hepatitis or liver failure. Acamprosate, which is primarily used to maintain abstinence, should be avoided in this patient with significant renal impairment. This patient has significant renal impairment where it is written. So why we are not giving acamprosate? It is used to maintain abstinence. Okay, okay. Yes, bupropion. Bupropion is an opioid partial agonist used in the treatment of the opioid use disorder and pain management. Valproate is an anticonvulsant agent used in the treatment of epilepsy and bipolar affective disorder. Neither of these medication is recommended for the treatment of alcohol use disorder. Bupropion and varenicline are the first line pharmacotherapies for smoking cessation, not alcohol use disorder. Okay. The aldehyde dehydrogenase inhibitor disulfiram is an aversive agent that causes an unpleasant psychological reaction, tachycardia, flushed skin, headache, nausea, vomiting when alcohol is consumed. It can be used only in abstinent patient and would not be preferred in the patient who is actively drinking. And candidates for disulfiram must be highly motivated or take medication in a supervised setting, as patient may skip a dose to avoid medication's aversive reaction when alcohol is desired. It is considered a second line agent that is used when naltrexone and acamprosate are ineffective or contraindicated. So main first line drug is naltrexone, but cannot be given in patient with hepatitis, and cannot be given in patient with hepatitis, and acamprosate cannot be given in patient with renal impairment. Hepatitis and other no. Hepatitis, okay. Liver problem, okay. Naltrexone for liver, and okay, next. Okay, so this patient's exposure to a life-threatening traumatic event, a 5 week history of recurrent nightmares, intrusive memories, avoidance, hyperarousal, and impaired concentration are consistent with PTSD. Research most strongly supports that in addition to PTSD, sexual assault victims are increased lifetime risk for major depression and contemplation of suicide or actual attempt. These patients are also increased risk for medical problems including STDs, pelvic pain, fibromyalgia, functional GI disorder, and cervical cancer. Okay. Do you want me to read all the options? Okay. Next. No. Okay. So it's postpartum depression. Okay. So although interrupted sleep is common in new mother, several features of the patient's presentation are concerning for postpartum depression. Major depressive disorder with peripartum onset, including making sleep disturbance with early morning awakening, low energy, motivation, forces herself to shower and care for the infant, leading to impaired functioning. Postpartum depression is common and is left untreated. If left untreated, can result in impaired mental infant bonding and negative impact on maternal and infant health. Therefore, all patients with mood symptom after birth should be further screened for postpartum depression. In this situation, asking about hopelessness in a patient who struggles to identify depression, I know it's pretty normal. I'd like better if I could just get some rest. Provides the physician with another way of determining the presence of depressed mood, sad, hopelessness, empty. If positive, if positive for postpartum depression, then appropriate treatment should include pharmacology and therapeutic intervention. In addition, who confirm hopelessness along with other symptoms of postpartum depression should be screened for the presence of imminent risk, suicidal ideation, In a patient with is actively suicidal or has thoughts of harming the infant, hospitalization should be pursued. Got it? Yes. Okay. The postpartum blues is a self-limited condition. Postpartum blue is a self-limited condition with milder depressive symptoms that is typically peak at fifth, 5 days of postpartum and resolve within 5 days to within 2 weeks. 5 days to within 2 weeks. However, this patient delivered 3 weeks ago, and her symptoms are more severe: terminal insomnia, low energy and motivation, impaired functioning, which requires further screening for postpartum depression and potentially treatment beyond some coping strategy that may be helpful. And option C and D: maximizing restful sleep by obtaining additional childcare support and or considering safe sleep medication options might be helpful for new mothers managing postpartum blues. However, assessing the patient for postpartum depression takes precedence because she would require more intensive treatment if positive. Okay, now look at the box. Postpartum blue, postpartum depression, psychosis. Postpartum blue prevalence is 40 to 80%, onset 2 to 3 days, results within 14 days. So it starts within 2 to 3 days, start within 14 days. Sorry, results within 14 days. In postpartum blue, there is mild depression, tearfulness, and irritability. Postpartum blue, postpartum depression, 8 to 15%, typically 4 to 6, can be up to a year. So 2, 3, 4, 5, 2, 3, 4, 6. Okay. Then more than 2 weeks of moderate depression, sleep or appetite disturbance, low energy, psychomotor changes, guilt, concentration difficulty, suicidal ideation. And the postpartum psychosis, it is days to weeks, delusion, hallucination, thought disorganization, and bizarre behavior. Got it? Hello? Yes? Okay. Is there any? A depression more than 2 weeks is MDD, major depressive disorder. Okay, first we try to find out the clue, then the timeline. Okay, so he has headache, unexplained weight loss, parsimony. Sorry. Yes. More probably yes. It may be MDD. Is there any other like he has psychosis, cancer? He says cancer in my wish. It's punishment. It is not. He is not faking. It's not somatic symptom disorder. Is uh because he is it persistent complex bereavement disorder? Okay. Okay. I haven't given yet. Um, so it's MDD. I was right. I thought that it is you have given the MDD. Oh, okay. In the absence of underlying medical illness, these patients weight loss, low energy, impaired concentration, loss of interest, guilt, psychomotor retardation are most likely due to major depression. His conviction and that has brain cancer despite normal test results that cancer is punishment for sins he committed as a child represents a delusion that specifies the subtype as major depressive with psychotic feature severe subtype of in this severe subtype of unipolar major depression. The depressive episode is accompanied by delusion and or hallucination, typically with depressive themes, deserving punishment, worthlessness, nihilism. Identification of psychotic feature is important because treatment for psychotic depression is different than that for non-psychotic depression. First line treatment for major depressive disorder with psychotic features is combination therapy, antidepressant and antipsychotic with ECT, electroconvulsive therapy. Okay. Uh, yes, yes. In delusional disorder, mood symptoms, if present, are brief, not a prominent part of illness. They would not they would not explain this patient's severe depressive symptoms. Other option like B and E, patient with illness anxiety disorder are excessively concerned about having a serious undiagnosed general medical condition. Somatic symptom disorder is characterized by excessive anxiety and thoughts about seriousness of at least one somatic symptom. Neither diagnosis explains this patient's severe depression, associated somatic delusion, and delusion of the guilt. Option D. Although this patient's depression may have been triggered by wife's death, his symptoms are severe and meet the criteria of major depressive disorder. Presence with persistent Patients with persistent complex bereavement, these are also known as complicated grief, commonly have depressive symptoms. but their sadness centers on the loss of a loved one. Their sadness centers on the loss of a loved one, and is characterized by intense yearning for the deceased. It would not explain the patient's pervasive depression and delusion. Okay, next. Sullen means bad tempered. Okay, he has pyromania. Okay, clinical feature: deliberate fire setting more than one occasion. Deliberate fire setting more than one occasion. Fascination with fire. Fascination with fire. Tension or arousal prior to act. Pleasure or relief when setting or witnessing fire. No external motivation. Financial gain. Political statement. Recognition. Differential diagnosis is cognitive disorder, antisocial personality disorder, mania, psychosis, impaired judgment, neurocognitive disorder, substance intoxication. These patients' fascination with fire and history suggests of intentional fire setting. Intentional fire setting are consistent with the diagnosis of pyromania, a rare impulse control disorder most commonly found in male patients. Pyromania involves deliberate fire setting with no obvious motive, financial gain, revenge, political statement, recognition to relieve internal tension. Individuals with individuals with this condition tend to be fascinated by fire and anything related to it. Fire station firefighter, cigarette lighters, they deliberately start fires to reduce tension and afterward feels pressure or relief. Pyromania must be differentiated from the fire setting associated with a manic episode, psychosis, conduct disorder, or substance intoxication. Disorder. Antisocial personality disorder. Uh, Antisocial personality disorder is diagnosed in individuals more than 18 It involves a pattern of violation of basic societal rules and the rights of others and requires a history with some symptoms of conduct disorder before age 15. Choice B, fire setting can also be a symptom of conduct disorder. However, in conduct disorder, fire setting is done to cause damage and is accompanied by fascination with fire or the need to relieve the tension. In addition, a diagnosis of the conduct disorder requires pervasive pattern of violating rules and the rights of others that includes additional problem behaviors, aggression, cruelty toward people and animal and theft, which this patient does not exhibit. And it's not all the normal adolescent is characterized by a desire for privacy, independence that may manifest as sullen behavior, arguing with parents, and testing limits, going to the party without his parents' knowledge. It would not explain this patient's fascination with fire and improvement in the fire setting. Oppositional defiant disorder is characterized by ang- pattern of angry or irritable mood and defined of irritable mood and defined behavior toward the authority figures. Although this patient is more argumentative with his parents, this is typical of adolescence and he has no pervasive pattern of defiance. Individuals with oppositional defiant disorder do not typically engage in the fire setting. Got it? Dysthymia means, as far I remember, if depression persists more than 2 years, that is dysthymia. It's not generalized anxiety disorder. Okay. So the patient with chronic insomnia has developed behavioral maladaptation, poor sleep hygiene that exacerbates sleep issues, including the following: making inconsistent sleep wake times, significantly different schedule on weekends or as weekdays, taking late afternoon naps, taking late afternoon naps, drinking caffeine in the evening, should stop more than 8 hours before bedtime, smoking, eating a late at dinner, exercising in the late evening, remaining in the bed and checking the clock frequently while awake. Initial management of the chronic insomnia involves improving these maladaptive sleep behavior, sleep hygiene. Other components of good sleep hygiene include avoiding the use of electronic devices before bedtime, maintaining comfortably cool, dark, quiet bedroom, using the bed only for sleep or sex rather than watching television or working. Patients do patients should do physical sorry patients should also physically leave the bed if awake longer than 20 minutes. It is also useful to address fears and unrealistic expectation around sleep anxiety, uh, thought education. Thought education. Collectively, these treatment has been standardized into a cognitive behavior therapy for insomnia. Okay, option A, delayed sleep phase syndrome is characterized by natural tendency towards sleeping and and waking significantly later than the conventional schedules. Patient typically Patients typically describe themselves as night owls and are most productive in the late afternoon or early evening. Unlike these patients who sleeps excessively on weekends when allowed to sit on mm, so-called option B. This patient does not experience chronic worries about multiple issues that are characteristics of generalized anxiety disorder. Option C. Although sleep disturbance is common in perimenopause, this patient does not report other symptoms like you are talking about, like hot flashes, menstrual irregular vaginal dryness, making the diagnosis unlikely. And insomnia, irritability, feeling down, and thoughts about the purpose of life are consistent with dysthymia. However, this patient enjoys work, socializes with co-workers, and has no other depressive symptom, anhedonia, guilt, loss of appetite, and low self-esteem, hopelessness. It is more likely that the mood symptoms are a consequence, not the cause of our sleep disturbance. Got it? Okay, these patients history of early foster care. These patients history of early foster care placement due to parental substance use, s- social withdrawal, lack of positive response to attempt comfort, and poor emotional responsiveness is consistent with reactive attachment disorder. Reactive attachment disorder may develop in children when abuse, neglect, prolonged institutionalization, or inconsistent care, frequent moving down between foster homes, mm, disrupts the development of a healthy, secure attachment to caregivers. Children with reactive attachment disorder seldom seek comfort and do not respond to attempt to comfort them. Other symptoms include lack of social responsiveness, lack of emotions, episodes of unexpected irritability or sadness in response to non-threatening encounters. Symptoms of reactive attachment disorder often improve when a child has access to consistent responsiveness attachment figures. Okay, choice A, adjustment disorder. Choice A, adjustment disorder is diagnosed when the response to a stressor is out of proportion to the circumstances and is typically accompanied by either anxiety, depression, or a disturbance of conduct. Social disengagement both at school and at home, as well as lack of response to comfort, are not typical. Adjustment disorder should be diagnosed when symptoms are best explained by another disorder like reactive attachment disorder in this patient. Okay, deficits in school and emotional interaction can be deficits in school and emotional interaction can be seen in both RAD and ASD. However, this girl interacts with the physician and does not display the restricted interest stereotype and repeated motor mannerism and language impairment commonly seen in ASD. Commonly seen in ASD. Her history of neglect hoarding, which is common in children who have suffered neglect, making RAD the more likely diagnosis. Okay, option C, disinhibited social engagement disorder is another possible outcome of severity. Early neglect is characterized by overfamiliarity with unfamiliar adult rather than a lack of seeking comfort. These children show a lack of boundaries when approaching adults, uh, sitting on another person's lap, living with a stranger. Got it? Okay, can we take a break for 5-10 minutes? I'm very okay. Feeling sleepy. Sorry.